traveled to historical Lafayette Square in Buffalo to interview Azeros owners Ron Zoeller and Kevin Gannon. The Robin Hoods of healthcare, Ron and Kevin talk about the disruptively innovative things they are doing to help employers and physicians. Listen as they explain how they lower costs, tell us what reference-based pricing is, and how Azeros and Cornerstone are working together to provide patient steerage to quality physicians.
Good morning. I was raised in the suburbs of Buffalo, Cheektowaga, New York. Went to Maryvale High School. Played a bunch of sports there. Ended up playing soccer at Kent State University after that. Had no idea what I wanted to do. I was a decent student in high school and not so in college. So with my third interview in the first 10 days after I graduated, Travelers Insurance in their health claims department offered me a job. I took it. Figured I'd find real work in 3 or 4 months. And 50 years later, I'm still in health insurance. I was an inside claims manager, supervisor manager for 13 years in 5 different offices. Ultimately managed the Buffalo, New York office and left in 1982 to be self-employed after a couple of bars. In a former life, I started our third-party administration firm in 1983 called North American Health Plans. And so I've been in the self-insurance business since that time, and we've gone from there. Yeah. We built a PPO of 17,000 providers. When I sold the company in 2005, we had 30 nurses on staff doing medical management. We had the first and largest high deductible health plan in the U.S., Definity, now United Healthcare in Buffalo, with 240 employees handling claims and customer service and medical management on one contract. So we had a big leg up in the high deductible HRA space. So we had an HMO for 4 years that didn't work. Named the ballpark in downtown Buffalo, North American Park, in that span to get, we got the meetings. It did work, but we just didn't have enough capital to sustain the initial losses, so we got out of that business. So since 2005, I've been in the stop loss business, consulting for 4 or 5 major health plans in the Northeast, and we started Azeros 2 years ago, in 2019.
Hi, Kevin Gannon. Born and raised in Lackawanna, New York. Went to Bishop Timon High School, where I wasn't such a good student at Bishop Timon, but a better student at Damon College. But both were great experiences. When I graduated from college, actually wasn't sure what I was going to do. I had a degree in marketing and went to go work at the John Hancock Insurance Company, selling life insurance right out of college. Did that for a little while, and then I literally ran into a gentleman by the name of Mike Flynn at a Buffalo Life Underwriters meeting. And this had to be in 1983, 84, I guess. And met Mike Flynn and went over to Cochran and Flynn. And I started working with Joe Michael, who headed up our group division. And oftentimes people ask me how long I've been in the health insurance space, and my answer usually is, it was when Blue Cross and Blue Shield were separate companies, and that's usually met with the response of, I never knew that they were separate companies. So we, Joe and I worked very closely together, and Joe started one of the very first health insurance consortiums, if you will, in Western New York at the time, and it was the J.P. Michael Health Plan, and he and I worked together for a number of years. And then in the mid-90s, I started Niagara Benefits Group, and then met Ted Sobolewski, who had Niagara Risk Management, which was a property casualty firm. And we put our 2 companies together and created Niagara Insurance Group. We began that in 1998, and we were acquired by Brown & Brown in 2004. And in 2007, I was recruited to M&T Bank's insurance agency, and went over to M&T for about 10 years and helped them grow their benefits division. That was a wonderful experience. Gave me an opportunity to work outside of Western New York and be exposed to different national health insurance carriers, different funding opportunities that I just hadn't been exposed to here in Buffalo, New York. And in Buffalo, as everybody in Western New York knows, it's not much has changed in a lot of ways. It's Blue Cross and Blue Shield, Univera, which is an Excellus company, Highmark, of course, has taken over the Blues of Buffalo, and we have Independent Health here locally. So essentially the same three carriers for many, many years. So that experience was great, again, because I got exposed to different national experiences. I left the bank in 2017. And during my time working with Joe, we were in Corporate Parkway, and I came to know Ron and his company and the success that he was having, primarily, frankly, outside of Western New York. And I was really intrigued by North American Health Plans and their growth. Not only their growth, but why they had such growth. And it came down to really the efficiencies that North American was able to deliver to employer groups, and aggressive and appropriate case and disease and claims management that candidly I hadn't really seen in the other markets and other carriers I had worked with. So I was always intrigued by North American, and I was fortunate that Ron and I ran back into each other during a marketing meeting in early 2019. At that time I was with Employee Benefit Concepts. They had an opportunity to be acquired by USI, their benefits division. And at that time I had a decision to make, go down that path or start Azeros with Ron in July of 2019. And it has been a wonderful experience from day one. And I've learned more in the last 2 years I know than I candidly probably had learned in the prior 20 or so. Not the least of which was claims management, reducing the expense to the employer. And for me personally, and I know Ron feels the same way, one of the challenges that I had the last several years of being in kind of the traditional broker market was it really began to bother me. The way I was raised in the business was the employer is our customer and the insurance company is a solution. And it began to bother me that relationship between broker and insurance company just began to get too close to me, that they would often describe it as a partnership. And in my mind, the way I was raised in the business, the partnership is between us and the employer group and the members and the employees that work for that company. So Azeros, we've created a very independent model to work with those employer groups, and we're doing things here in Western New York and in upstate New York, and we will be doing throughout the Northeast that are happening in other parts of the country, but they're not happening here. And I know we'll chat a little bit more about. And the other frustration that I began to witness, and Ron and I chatted a lot about this as we started to launch Azeros, was let physicians practice medicine. And not be encumbered by the restrictions and the rules and so on that the insurance companies put on them, and to free them up to spend the time that they need with their patients and their families, and provide appropriate care without worrying about the time on the clock. So that's part of our message as well.
As Kevin indicated, we launched Azeros in 2019. Our company, though we were based in upstate New York, and that's where all of our business came most of the first 5 or 6 years, we ultimately opened a sales office in Boston, Massachusetts. We ultimately bought 10 TPAs, 1 in New York, 2 in Pennsylvania, 1 in Massachusetts, 2 in Georgia, 2 in Indiana, 2 in Missouri, so 1 in Ohio. So we got to see what was happening with healthcare in other parts of the country. And we had to manage those health plans and recommend changes if we thought it appropriate, and sometimes there was politics involved that we had to deal with. When we put on the Notre Dame health plan, they were affiliated with St. Joseph's Hospital System in South Bend, Indiana, in which we had just taken on 17,000 members in an HMO plan doing the claims administration for. But they had a significant relationship with, we took on the health plan for Community Hospital in the same town, 2,600 employees, and we're dealing with both at the same time. And it was wonderful. Both parties loved us, even though they competed and really weren't crazy about each other.
Right.
You know, that kind of stuff, you learn how to deal with it. And, you know, back here in Buffalo, it was the same old all the time. And, you know, you had 3 health plans that dominated. I mean, we had several nice direct clients, M&T Bank, Fisher Price, Toys, and a couple others. That we wrote direct. We never got any cooperation from the brokers in Buffalo. But, you know, so we got those direct. And then we started marketing. We had a lot of clients in Syracuse, New York, Jamestown, New York, and then in New England as we spread our wings into Western Massachusetts and Vermont. I think we had 15 clients in Vermont, self-insured, and there are only 700,000 people live in the whole state. But we built a PPO network there as an adjunct to our upstate New York PPO. And ultimately we had thousands and thousands of providers in the Northeast with direct contracts where, the big carriers, weren't even paying attention to that stuff. So we saw that the cost containment opportunities, and things have changed over the years. We'll talk a little bit about reference-based pricing and international pharmacy, specialty discounts and stuff like that. Those weren't around then. But geez, back in the late 80s, plans weren't even doing, pre-admission certification. Doctors were admitting patients into the hospital on Friday for Monday morning surgery. I had a hernia surgery. The doctor tried to put me in on Sunday, and I wouldn't go. And he was upset with me because he wanted to do the pre-admission testing. I drove to the lab, and I upset my attending physician and the surgeon because I didn't do it according to their schedule. But I knew I didn't have to be in the hospital on Sunday for Monday surgery. Nobody was doing that back then. So the things going on and other, the high deductible stuff with an HRA that nobody knew even what its HRA stood for in 2003. We were handling the largest plan in the U.S. With 130,000 employees we were paying claims for within a year of taking over that contract. That is now United Healthcare's office in Buffalo. We spun it off. Not too many people know that.
Right.
My former company, North American Health Plans, is now Aetna in Buffalo.
Right.
So those are the things that we were doing in the old days that have changed a little bit. But Buffalo's a very conservative community. Rochester very conservative, and no surprises there. But we're out there getting the message direct to employers and the few brokers that that really care about trying to eliminate the 7 to 8% annual medical inflation that can only be abated through greater employee contributions and higher deductibles. And how high can the deductibles go? They're up to $1,000 to $2,000 for many plans now. Employees can't even afford basic medical care with the deductibles that are in place. At least due to the Affordable Care Act, they get preventive care that must be provided with no copay.
Right.
But a lot of you've got your child has 101 degree temperature. You may not want to take them to the ER where it's going to cost you a $500 copay possibly. You just don't know. So so that's why we launched Azeros, to do those things that other people weren't doing.
The high deductible health plans, unfortunately, they have, you're right, they've become a deterrent for a lot of families to care. The Affordable Care Act, of course, shored up a lot of that, but they become a deterrent. Same in the pharmacy space, a lot of co-pays. I don't think a lot of employers really realize that their health insurance carrier is subcontracting, if you will, all the pharmacy services to either a national PBM, pharmacy benefit manager. And it's when we get into the weeds, and really, if you think about it, the health insurance product, there's only two components of cost. There's the administrative expense and the claims expense. And even in the Affordable Care Act, the allowance, if you will, is up to 15% to be spent on the administrative expense. And the models that we're looking at in our program, we've reduced that down to 4%.
No more than 6, and 4 to 5 is probably the norm. When I sold my TPA, we were paying $2 billion a year out in claims. We were paying out more than independent health in Buffalo. Nobody had any idea that we were that size. Our average fees were about 4%.
So as Azeros began, as Ron and I, started on this journey. For me, it was really interesting. I asked Ron early on what I was familiar with North American. I knew the success that they had. And I remember, again, when I was working with Joe over at Corporate Parkway, I would go into your office and take a tour of the claim shop, and I thought, wow, this is a really well-oiled machine. And as we launched Azeros a couple years ago, I loved when I said to Ron, what made it so successful? What was the differentiator? And I loved your answer. It was, we paid claims correctly in the first 5 days, get them out the door, and we answered the phone, live answer, live person answered the phone in 3 rings, and It was the simple things, the simple blocking and tackling that worked. And I loved your comment about, well, if you pay a claim the right way the first time, you don't have all these issues. And
that came up. We were a finalist with 6,000 employees in the city of Springfield, Massachusetts.
Right.
And we were a long shot. We were competing against 2 TPAs that are domiciled in Massachusetts.
Right.
The public sector clients, it's going to be tough. But it was a Friday afternoon, which is kind of unusual. We're traveling from Buffalo, but that's their schedule. So at the end of our presentation, one of the city councilmen asked me, he said, "I love your presentation. You've got a great reputation, but your prices are the cheapest of the people we're talking to. How do you do it for that price?" I said, "It's cheaper to do it right."
Right.
If you pay the claims the first time they come in, you don't have the doctor send the second one you have to look at.
Right.
If you pay the claims fast, the people don't call.
Right.
So we can spend more time on paying the claims that we were hired to do.
Right.
It's a simple answer, but it's the truth.
Yeah. So those same disciplines are what we've applied at Azeros. And so we've partnered with different independent third-party administration companies. We have a preferred arrangement with a pharmacy benefit management company, Raya, outside Albany and Latham, New York. It is truly a transparent PBM. The rebates go 100% back to the employer group. We have vetted out a couple of different opportunities in the international pharmacy space. And it is amazing to all of us and to our employer groups when we illustrate these, the savings opportunity for essentially doing mail order international pharmacy. And if you can, as an example, Humira is a fairly common prescription, but if we can get Humira to go from where it is literally manufactured to the employee or the member's home, I'd argue that we have an obligation to do that. Humira is Humira, and if we can deliver that, of course, there's coordination between the physician and the employee's physician. But it's not so many years ago, mail order medication came out, and the whole idea was, well, if I can get a 90-day supply mailed to my house and waive a copay as an incentive to the employee, let's do that. We've done that in the domestic waters. We do have an obligation, I think, that if we had that opportunity with international pharmacy, on July 9th, President Biden issued the
asking all public sector municipalities and school districts to look into international pharmacy.
Yeah. So it again gave another layer of credibility to us and for our employer groups that international pharmacy is absolutely an enormous opportunity.
Follow up on Kevin's comment about Humira. It's made mainly in Switzerland, I think, but Western Europe. The same drug that you would pick up at a specialty pharmacy in your hometown that will cost $6,000, will cost $4,000. We ship it to your home for your employer. And you have no copay. It's in most of these specialty drugs that are on our list, and we've got dozens and dozens. It's about a 30% savings, and nobody is offering that in Buffalo. The 4 national pharmacy benefit managers control 80% of the marketplace, and the profit margins built into that. You can imagine what they are because they're getting that $6,000, and they're paying probably 3. If we're getting it for 4, they can probably get it for 3 or less. So it's not a good system, but it's a system we have, and the pharmaceutical manufacturers and the PBMs. They have such strong lobbyists. The system's not going to change in the near future.
Right.
So if we can get it shipped, consistent with federal, laws and regulations, why not?
Absolutely. Well, it not only saves the employer's health plan money, it certainly saves the employee on the copays and so on. Their out-of-pocket expense. Further, when we're looking at stop-loss insurance for the employer group. For all of our clients, of course, you have specific and aggregate stop-loss insurance. But the difference when you work with Ron and I and our company Azeros is we're painting a picture to the underwriter of the stop-loss carrier, and we're talking about all these things that we're doing, steerage to limited networks, access to national centers of excellence, be it the Cleveland Clinic or Sloan Kettering or the Mayo Clinic, et cetera. If you have access to those centers of excellence and you know that they are for better outcomes, and we are fortunate, certainly in Western New York, that we have a number of very, very good hospitals. However, there are certain certain situations where these other centers of excellence are just more appropriate. And to give an employee and their family member access to those, we have an obligation to do that. So in the stop loss space, as we explain the exposure to the underwriter, the stop loss carrier, all these things, they reduce their exposure. So if we're limiting the access, limiting the steerage to centers of excellence, introducing international pharmacy. We'll talk a little bit more about direct primary care centers and the success that we've had in Pennsylvania with those. All those things reduce the claims expense, and we're managing the claims expense appropriately. And on the front end, to the employee and the family member, delivering excellence in customer service. Those are a lot of the principles that really gave the momentum, if you will, for us to launch Azeros. So it's been really interesting. I have 35 years of experience being on the other side of the fence that you were on, brokering through all these different insurance companies, and always tried to be on the cutting edge. I remember years ago, one of the first things I had done was carve out pharmacy, and that was unheard of in Western New York, and that was just an unusual thing to do, but in my mind it just made all the sense in the world that if we can go direct for the benefit to the employer and the employee, then we should do that. So what I learned on the broker side over the years, and what Ron certainly grew and learned as he grew North American, that coming at it from both of those angles and delivering that to the employer, it's made for some really interesting conversations and some really exciting outcomes.
You probably inferred from our previous comments here that
we're proponents of self-insurance.
Yeah, that you can do things that you can't do in a fully insured environment or a self-funded environment with a traditional carrier, because they don't want to do unique stuff.
Right.
Their whole company is built on the PPO model, on the contracts that they have, and they're not going to do anything to upset one of those providers by steering you somewhere else. Right. So on the front end, we design the plan with you. Self-funded plans are not governed by any states. There are no state regulations applicable to a self-funded plan, just federal. You've got to comply with ERISA, COBRA, HIPAA, those federal laws, and non-discrimination under ERISA, of course. But plan design, you can design it any way you want. Deductibles, co-pays, steerage, as Kevin mentioned before, and so we can design it if you've got a favorite provider in your town, or a cost-effective provider, or a quality, ACO or medical group. We can steer, pay 100% to one provider and 80% to another, where the carriers will never do that.
Right.
Building all of this is medical management. The high dollar claims, nurses, RNs will look at it on the front end, but we can put in, a myriad of features on the medical plan or on the pharmacy plan, and then we will work with you on. As Kevin mentioned, Araya RX out of Albany is our preferred PBM, but we can work with any of them. They all need the same data, enrollment data, to set it up. But we often use your current plan as a starting point, deductibles, etc. But then we present you the options, and ultimately the employer is a plan sponsor. The employer is going to fund the claims, pay us a per employee per month administrative fee.
Right.
Buy the stop loss. There's two types of stop loss that will protect your plan. Everybody buys specific and needs to buy specific stop loss. So if you had 200 employees and your annual spend is, let's say, $2.5 million a year, we would recommend typically take about 4% of that and buy a specific deductible plan of about $100,000 deductible per claim. So if you get a $150,000 claim, you've got the first 100. But you can fit it within your $2.5 million budget, and the carrier reimburses you $50,000 above that deductible.
Right.
Aggregate stop loss protects the whole plan, so that in that same example, if you had $2.5 million expectation of claims, they typically set the attachment point at 125% of that. So you'd add $625,000 to that number, and your attachment point would be $3,125,000, at which you won't spend any more than that. No more than 1% of the cases nationwide, I think, hit the aggregate attachment point, but we call it sleep insurance.
Right.
So if even with the pandemic, I don't think we had any employers,
Right.
hitting their aggregate attachment point. But it is there in case you feel more comfortable. Once you have 300 or more employees, you can take that premium of $20,000 a year and buy down your specific deductible. Yeah. So if you would add 100,000, buy it at 90.
Yeah.
And use the same premium more cost effectively.
I think that's probably been one of the more eye-opening things that we've showed employer groups. As an example, if you look at an employer group and if they have 200 or 300 employees and they're fully insured with name your insurance carrier, typically most employers are prospectively rated, and within their prospectively rated program, they have what's referred to as the pooling limit. And oftentimes the pooling limit could be $100,000, $125,000, what have you, in this fully insured program. And a lot of employers, they don't, not their fault, but they don't really understand what the pooling limit is and what it really represents. And a lot of times we'll come in, we'll explain what the pooling limit is, and then we'll show them in the self-funded, because there's a perception on the street that if I go self-insured, I'm at risk and I'm going to bankrupt my company, and there's all these terrible things are going to happen. And it's really interesting that oftentimes we'll show an employer that your pooling limit within your fully insured plan, as an example, is $120,000 or what have you. And we'll say, well, in ours, we're showing you a specific deductible in your self-funded stop-loss insurance of maybe $100,000 or maybe the same $120,000, and then the aggregate coverage on top of it. But then when we model out the different components of cost, the rebates that come back to the employer, that we work on a fee basis. So as I love to say, when you get a rate increase, it doesn't mean that I should get a raise as your commission broker. If I'm getting 2 or 3% commission on my health insurance plan and my client gets a 10, 12, 13, 14, 20% rate increase, I get a raise. Well, I'm not so sure that that's really fair to the employer group. I don't think I should get a raise if you incur a huge rate increase. So the model that we have, and I lived in that world for a long time, and over the years, I frankly tried to get away from that percentage of premium as compensation and get into more of a fee-for-service model. And clearly that is what our model is, as Azeros, it is on a fee basis, complete transparency, not only in our compensation, but on the entire, it's really simple. It breaks down to a few components of cost. You have the administrative fee to us to manage your program. You have your stop-loss premium that you pay directly to the stop-loss carrier, and you pay your claims as they're incurred.
This is not complex. We wouldn't be doing it if it were.
Oh, no, not at all, Ron. No.
We keep it very simple. And actuaries, but
no.
Give us an $8 Walmart calculator. You can figure out what your costs are going to be next year.
Absolutely.
Accepting the catastrophic claims you might have incurred last year.
Right.
It's simple stuff. The carriers know that, but they spend millions of dollars on the underwriters and actuaries. They probably, maybe they feel they have to, but it's not. Yeah. For a small group, it doesn't even matter. If you got 20 employees, you're going to be fully insured the rest of your, the rest of the existence of your company. That's just, you have to be pooled. But over 100 employees in some states, you go out to the Midwestern and down south, 60, 70, 80 employee companies are self-insuring and have been for 20 years. In New York, it's unheard of.
Yeah.
And, but that was unheard of even before they passed. The insurance department ruled that you had to have 100 eligible employees before you could buy stop loss, in effect prohibiting you from self-insuring, which not coincidentally increases their premium tax that they collect for those that are under 100 employees.
Right.
That was an accident, though. Yeah. They didn't mean it.
That's right. And unfortunately, I would argue in New York State, it is. If you're anything under 100 eligible, you're community rated. And community rating, it has its place. There is no doubt that it has helped an awful lot of employers and employees throughout New York State. So community rating does have its place. But even within community rating, again, because we are independent, we can help that employer in the community rated waters as well and look at high deductibles. And a lot of the solution over the last several years was, let's go to a high deductible health plan. We'll introduce a health reimbursement account. The employer will fund it in an effort to keep the employee whole, or as whole as they can. And that does work, and it works for a while, but as the rates continue to increase and the deductibles continue to go higher, that becomes a bit of a challenge in itself. So one of the plan designs I love that Ron came up with recently was, well, let's look at a high deductible health plan. Let's look at high community rating appropriately. Let's look at high deductible health plans. But instead of a health reimbursement account, let's look at steerage to limited networks underneath that deductible. So that is something very creative. It's a pretty neat plan design that you came up with.
Instead of having 2,500 to 3,000 doctors that Blue Cross, Independent Health, and Univera have, that first tier, the second and third tier, third tier's out of network, but the second tier has all those doctors in it.
Right.
But the first tier has 400 to 500 doctors that we've got good pricing from, and you can go see them with zero copay. Right. And especially on the primary care side, that it may not be that we'll have zero copay for inpatient hospitalization. That's going to be $20,000 bill anyway. But we want people to get primary care.
The other thing that's part of there were a lot of reasons that we started Azeros, and not the least of which was reference-based pricing and how that's taken off in other parts of the country, in the Midwest and in the South. Reference-based pricing is essentially where your claims are paid as a percentage of Medicare, and it hasn't been really introduced in upstate New York, but it is an enormous opportunity for employer groups to really manage the cost of care. And one of the first clients that we had down in Pennsylvania was already in a reference-based model. And I love that account because it led to your negotiations with the hospital system, and we negotiated a percentage of Medicare at the maximum with no balance billing. So on the street, as I like to say, there's all this noise about reference-based pricing, and it'll never work here, and it won't be accepted by the employer groups and so on. And in our opinion, nothing could be further from the truth. When you sit down with an employer group and you say to the owner of that company, or the CFO and the HR folks, and say, we are not restricting your access to the physicians. We are not restricting your access to the hospital systems. What we will do on your behalf is give access to the employee the same as they have today. But when it comes to the claims expense, instead of us being limited or obligated, if you will, to the contractual obligation that the traditional health insurance carriers have to those health systems, we will negotiate on behalf of the employer group a reimbursement as a percentage of Medicare. And that is when you're really working for the employer and their members. And it has to be fair to the hospitals, certainly. Medicare in itself, many would argue, is not enough if we went to a totally Medicare reimbursement system. But if Medicare is here and the fully insured traditional insurance carriers are here, if we can negotiate a percentage of Medicare, and we believe that 180 to 200% of Medicare is probably a fair reimbursement, the savings to the employer are enormous.
The RAND Corporation, which almost everybody's heard of, did a study 2 years ago. The average reimbursement after discounts nationwide was 241% of Medicare. Right. And that's after a 20 or 25% or 30% discount that the carriers might get. Right. And the hospitals have had it their own way forever. They've been able to set the bar and raise the bar, and they're getting 7 to 8% increases annually. And somebody's got to put a halt to it. Doctors started taking fee schedules back in the 1980s from HMOs and then PPOs. The PBM's actually doing a service when people are paying retail prices to the pharmacies and bringing home the receipts for the $17 script, and we call them shoebox receipts when our claim department got them in at the end of December for the whole year. But $200 was a lot to spend now. But so PBMs did a good job back in the 1990s when they were organized. Now they're part of the problem, not part of the solution. So we're just trying to reinvent what happens here in this area. Reference-based pricing started in Texas like 10 years ago, and do our hospitals love it? No. Sometimes our goal is to negotiate with them, but if we sit down with them first, they're going to say, "We'll see you later." You're going to. Your 500 life group is going to pay me the same per confinement as a 2 life group paid through Blue Cross. Yeah. And why doesn't our client get more consideration? Because we're putting a lot more people in that hospital. Right.
Well, I think part of the education to the employer and the employees is how the reimbursement works. In other words, yes, it's a percentage of Medicare, but what you did at North American, when you're being proactive on that claim, and you're reaching out to the employer and the hospital and saying, no, the way that we're going to do it isn't the traditional way. You are not going to have to wait for those dollars to come in.
We had a whole unit negotiating.
Right.
When I sold the company, we had 28 people in the cost containment unit. Probably
Right.
10 of them were negotiating.
Right.
With hospitals and other providers around the country, centers of excellence, whatever,
Mm-hmm.
because we knew it was a normal fee and an appropriate fee,
Mm-hmm.
and they knew that we knew.
Right. So you take that same methodology, apply it, to upstate New York and frankly throughout the Northeast. It's really been interesting. Much of the work we've done has been in Pennsylvania in the reference-based space, and it's almost becoming the norm, to the chagrin of the traditional insurance companies down there, I'm sure. But it is appropriate, it is manageable, and it I dare say is once the hospital system, as we experience in Pennsylvania, once they understand it and they realize that there is actually a cash flow opportunity back to the system and to the surgeons and the physicians, that there's an opportunity on the front end that they just aren't aware of today. So a lot of what we explain to those populations is this is how it works. We know that the reimbursement has to be reasonable to the hospital systems, but it does not have to be at the high level.
There are exceptions. UPMC in Pittsburgh, you don't want to go near.
Well, that's true.
They own 12 or 13 hospitals in Western Pennsylvania.
Yeah. And they're the insurance company.
And they're an insurance company down there, so they get it both ways.
Yeah.
And they don't want to. I don't think they negotiate with anybody. We are proud that we are on their website as somebody you should stay away from.
Right.
We do that nasty stuff called reference-based pricing.
Yeah. The employers love it, but the hospital, UPMC doesn't. They didn't love it, but that's okay.
I don't know why they're complaining. We had a $300,000 charge from 2 confinements for 1 patient. We allowed 50.
True. The employer didn't mind.
Humor.
Right. The
And
employer
that
loved
allowance was 150% of Medicare.
Yeah. The other piece, and it does dovetail, and over my career, and I know over Ron's career, I have always tried to be ahead of the curve, whether it was pharmacy carve-out or different funding methodologies or what have you. Reference-based pricing is, without question, will be here, and the experience that we've had in other markets, including primarily in Pennsylvania, has been it's been incredibly helpful, and it's really been interesting when we talk to the stop-loss carriers. When we explain reference-based pricing and limited networks, I remember one of the very first cases that we showed direct primary care center and reference-based pricing. We had about a 15 to 20% reduction off the aggregate attachment point and off of the premium. So at the risk of getting too deep into the weeds, that 15-20% is very meaningful dollars to the employer. And it all trickles down to the employee. What's the employee contribution? How much is coming? I've said for years, what employees want to know is my doctor in the network and how much is coming out of my paycheck? And we can help them with the who is in my network and how to access that network, whether it's a non-traditional method or through limited networks, through steerage, or through reference-based pricing. And when the employee realizes the opportunity to reduce their payroll deduction to a health plan, people follow the money and they want access to care. And that's why these high deductibles, a lot of people early on, they went to it, people would say, I never use this health insurance, give me the highest deductible because it costs me the least out of my pocket. That's okay until you have a problem. So we want to manage that plan design and that network access and distribution and the reimbursement. And reference-based, it is an appropriate reimbursement to the physician and the hospital, but it does have to be managed. And we're fortunate that we have that experience, so much so that United Healthcare, we've had dialogue with them about, frankly, partnering, if you will, with United on how we can bring their reference-based solution to Western New York for employers to finally have an option beyond the local 3. So that's been really, really exciting.
reference-based clients we have in Pennsylvania, I'm working on some plan design changes they want to look at for the coming year. Their single rate for the last 12 months has been $370 premium equivalent,
Right.
including fully loaded,
Right.
pharmacy, stop loss, admin, etc. Their family rate's $925. Those rates are half of what they are in that area of Pennsylvania.
Yeah.
Probably maybe 60% of what they would be in Buffalo and Western New York.
Yeah. So
Unbelievable.
the premium equivalents.
There's no noise from the providers.
Not at all. Well, and I think part of that, it goes candidly to the contract that you negotiate with the health system. It's a reference-based client. It is a percentage of Medicare with no balance billing to the employees. But it was interesting when we were chatting with the hospital system, one of their concerns was leakage to competing hospitals. And they felt that we have an employer within the footprint of our hospital system. We don't have to worry about leakage to other competing hospital systems.
We designed the plan so that they would get in return for the good pricing,
Right.
that they would get steerage to their facilities and not to UPMC or other hospitals that are out of area and may not have any more quality.
Right.
And it all worked.
And as that plan design and as that message, as we begin to deliver that message in upstate New York in particular, I have every confidence that the hospital systems will set up and take notice and say, one of our worries is about leakage as well. You think in upstate, in Western New York, we have two competing hospital systems, and you see that, if hospital system A got a new MRI machine, hospital system B feels compelled to go out.
It's only $3 million. Who cares?
Yeah, exactly. Go get another. They
have
to have the same
per patient per confinement next year. Who cares?
Yeah. And so do we really need two in the same neighborhood?
I don't want to go 2 miles to get to the other one.
Yeah, no. We'd argue not. So let's
We got more to delete, I guess.
Yeah. Yeah.
I've always been a Bills fan growing up in Buffalo ever since they were in the American Football League starting in 1960. I remember just listening on the radio. I think I went to 2 home games ever in the old rock pile because we were a very modest income family, and that's what we couldn't afford it. But most of the games weren't televised back then. Actually, I watched the Cleveland Browns on TV more than the Bills way back then because there weren't many telecasts. But I've been a huge fan ever since, and a season ticket holder for almost all the time since 1984. And very concerned in the mid-90s when Ralph Wilson, the owner of the Bills, was threatening to move the team, and he was not happy with the revenue being generated from the stadium, especially with the suites and club seats. As I came to learn later, that revenue is maintained by the home team. The rest of the revenue in the stadium, I think, is shared 60% home team, 40% visitors. But in a meeting later on with NFL Commissioner Paul Tagliabue, he told me how that all started with the Dallas Cowboys in the mid-'60s. When they built a stadium, they didn't know how to fund it. They asked them if they could build these special seats and keep the extra revenue. And the NFL said, sure. And that was the precedent for what became a common way of helping to fund new stadiums. I'm sure the Bills have that built into their plan and their model for the proposed new stadium in Orchard Park. So in '95, my company was growing, but I don't think many people in Buffalo knew who we were or who I was, and self-funding was hardly being done here, and I hardly made sales calls in Buffalo. But we had the naming rights to the ballpark, so we had some corporate credibility out there marketing our fully insured HMO product. And then I was reading the newspaper I think it was the second last week in December of '95 when Cleveland had just had its last home game. They showed John Big Dog Thompson crying on the field because they were moving the team to Baltimore. The owner, Art Modell, was said to be the most hated man in Ohio back then. It was very emotional for Browns fans, as it would be if we lost our team in Buffalo. And I said, that can't happen to Buffalo. So I had this idea, and I called my friend Mike Bellani, former general manager of the Bisons. And I said, Mike, I got this crazy idea. He was a friend of mine. And I said, I want to bring up what if I brought the Cleveland Browns dog pound to Buffalo? A whole busload of fans for the Miami playoff game, which at that time was going to be a week from the following Saturday. The Bills were already in the playoffs. They had one more game, but it wasn't going to affect their playoff seeding. I said, what if I brought these people up to Buffalo to highlight that we could lose our team like they've lost their Browns? And Mike said, I think it's a hell of an idea. Let me call my friend Eric Brady, who writes for USA Today Sports. And I knew the name. I said, you know Eric? And he said, yeah, he used to write for the Courier Express when I was there, which went defunct in 1982. He calls, this is a Tuesday, he calls me back Wednesday morning and said, not only is Eric think it's a great idea, he's going to publish this story on the front page of USA Today Sports Friday morning. I said, you're kidding me. And from, I immediately, we had to go to work on getting it arranged. On Thursday, I called the Dog Pound Lounge, which I thought was in Cleveland. It was closer to Dayton, Ohio. We invited a whole busload of 44 Browns fans that ultimately came to Buffalo. And from there on, and we tailgated. All 3 Buffalo TV stations were interviewing us at our tailgate. It was Bills fans were stopping by our location 200 feet from Gate 4, and we had end zone seats like Dog Pound always did in the Cleveland Stadium. And it was admittedly it was a party. The Bills blew out the Dolphins that day. So from there on, I was getting interviewed by the print media and the radio and TV stations. Anytime this Bills issue came up, I was called, and I didn't ask for it, I didn't look for it, but I just wanted to highlight that we could lose the team. Ultimately, the Bills signed a lease with Erie County in '97, but they had to sell they were building 65 or 70 new suites. They were going to build new club seats that they not had before on the second level of the stadium, and none of this inventory was going. And we all know that Buffalo doesn't have any Fortune 500 companies. I think in all the last 50 years they've had one. But the sales were going poorly, and I didn't know it. I was on the Buffalo Niagara Partnership board, but they kept me out of the loop because I think nobody trusted me from the Bills organization, that I had some ulterior motive like buying the Bills, like I had $400 million sitting in the bank somewhere. But ultimately, I was called to a breakfast at the Buffalo Club. 3 influential business people in Buffalo, not important who they were, asked me to join this Business Backs the Bills committee they were forming that was going to meet every Monday for the next 6 months. And as we got up to leave breakfast at this club, they asked if I'd be vice chairman, but I said, really? I said, I've written a memoirs book, and I think in the book I said something like asking the freshman geek to join the football team, to join the fraternity that has all the senior football players, in a big university. I said, I never played in their space, and they knew it, but they asked me to be vice chairman. Many years later, or many months later, after this project ended successfully in December of '98, in February of '99, I had lunch with Jeff Littman, number 2 at the Bills, who was on that committee. He came in about every other week for the meetings. And it didn't go well between him and myself for the first couple of months, admittedly. But we become friends and respected each other. And I said, Jeff, I got to ask you, was I invited on that committee because you thought I could help sell suites, which I sold 4 personally? But I said, or was it just so you could keep an eye on me? With a smirk, Jeff said, yeah, it was keep an eye on you. So behind the scenes, we were contacting every company, mid-size or large, some that had suites. Could you take a second? That was not normal. But mid-sized companies that we thought could afford a suite, the cheapest suites were around $17,000. Most expensive were $100,000. But we needed inventory sold fast because we had, including the legacy suites that were still open, and the new ones, we probably had 70 or 75 suites that had to be sold. And ultimately we got it done, but the club seats weren't going. The Bills were taking care of that, and their marketing department back then was pretty poor. I mean, I already owned 2 suites, and they were asking us, I was getting letters, would you want to buy a suite? They didn't even know who owned the suites there. M&T Bank, I mean, at least you could think my company nobody ever heard of, but M&T Bank got a letter. And they had 2 suites right on the 50-yard line. They had them for 30 years. So it was silly, some of the stuff going on with the Bills. And our committee had no website, we had no dedicated phone number. It was just 15 of us calling each other every, and meeting an hour and a half every Monday morning to go over our list of who was contacted. Some people could easily afford them. The companies didn't buy them. Other companies that were really small did me a favor or did us a favor in buying a suite. I remember talking to Carl Montante at Unilin. I don't think Carl might be saying this. I called Carl, and we had 80,000 square feet in one of his buildings in Corporate Parkway. I said, Carl, I need a favor. I need you to buy a suite. He said, Ron, I just bought 10 club seats, which are more expensive than the suites I was selling. I said, Carl, I need a suite. Can you buy one for me, please? And he said, oh, okay, Ron. He got me back the next year with some charity he was supporting. But that stuff was going on with everybody on our committee. We thought we had done it. We had an affiliate committee in Rochester that worked on their own. We got a few sales out of Rochester. Jamestown didn't go that well. We put them in a big common suite in the end zone. The small Jamestown companies that would participate. Toronto, we know that there are a lot of Bills fans in Canada, but the corporate environment there did not help us at all. But we learned as we went. Erky Kilborn, our chairman, I was vice chairman, would get in his plane he owned, and he'd fly to Corning and Albany. He'd fly around, doing his best to help us. And it was a team effort. And one thing that did frustrate us, the Bills would not give us an accounting. We had an idea. We knew which suites we had sold and about what the total inventory was. When it started, there was about 12 million a suite club seat inventory. 4 million had already been sold, people that already had suites. The other 8 million, and the goal was to hit 11 million. And we were keeping our own numbers, and we knew we were close, but literally the 6th month was ending, and we weren't sure that we had reached it because the Bills wouldn't give us an accounting. They made a phone call to us. They asked all of us to show up at the stadium, and they told us literally in the bowels of the stadium one day that we had succeeded and that the team was going to stay. And it wasn't like they had a plan to move immediately, but we knew if we didn't, none of us knew for sure if we missed the goal by a little bit what was going to happen. Nobody was talking at the Bills. And the only one that could talk was Ralph. Nobody else had the authority. And it did bother me. He never came to any of our meetings. And, we did get some Bills jackets at the end of the 6 months that, he paid for. And he paid for a week for our committee and spouses to fly out to Hawaii for the 1999 Pro Bowl in February. And we really appreciated it. It was a great week, a lot of fun. So I remember we were in a bus going from our hotel to the Battleship, Missouri on Wednesday night. They were hosting, the NFL had a party there, and we were part of it. Had to be 1,000 people on the dry dock to Missouri. And I said to somebody on the bus, and we're all with our spouses, and I'm sure we had a drink or two before we got on the bus, and it's a party week. And I said, geez, I hope nobody back home finds out we got a free trip to Hawaii, all of us, for the week. One of the guys in the back of the bus hears us talking. He walks up and he hands us an article that was in the morning paper in Buffalo from Don Esmond, who had taken shots at Ralph throughout that 6 months. And we actually met with Don on the side to say, Don, can you cool it a little bit? Instead of criticizing the billionaire owner, Ralph Wilson, because we were trying to get him to keep the team in town. And this article in the Buffalo called it Ron and Ricky's Excellent Vacation was the title of this article. I think I got a frame somewhere, but so the whole town knew that we had free trips to Hawaii for the week, but quite frankly, I think we earned them from most. I think I spent a day and a half a week for 6 months working on behalf of the Bills, and we got it done, and it was a team effort. Top CEOs from M&T Bank and Reed Midland, now HSBC, Fleet Bank, and other, Peter Hunt from Hunt Real Estate, Stan Lipsey, editor of the Buffalo News and CEO, Reg Newman, CEO of NOCO, Louis Kahl, CEO of the NFTA. There was, not me, there were some big hitters on that committee that were very influential. But we got it all done.